All right, so hypertensive bleeds. So going back to our, you know, hypertensive bleeds from, whether it be long-standing hypertension or it be due to abuse of drugs, or it be due to something that's causing a blood pressure to rise, right? We know that high blood pressure can cause aneurysms, but just as high blood pressure in general, what do you want to do? You want to get the blood pressure under control. And what is under control? There's a lot of different numbers out there. But basically, you think of 140 to 160, that's going to get you by 90% of the time, right? Some say, oh, no, it has to be 140. Some people say, no, it has to be 160. Someone says, oh, what about 150? And someone's like, 155. It's just 140 to 160 is usually accepted, right? What's not accepted is 130, 120, 110, 100, 90, 80, 70, right? That is not okay. And why is that not okay? Right? So we have our brain is trying to compensate for the inadequate flow it's getting to the ischemic areas, right? So this area of ischemia right here is not getting the flow, is barely getting the flow it is, right? We cranked everything up. Here's our MCA and our ACA are feeding this area that got blocked, right? And then all of a sudden, what if we drop the blood pressure, right? So the blood pressure went from those really, really thick arrows to these really, really thin arrows, right? So now this area does not get the flow it needs, right? And now that area is going to get ischemic, right? So here, just picture, here's our MCA, here's our ACA. ACA kind of wraps around and kind of feeds this side, right? Our MCA comes around this side and feeds this side. So if we just crank the flow from 11 down to 1, right, now this area starts to get ischemic, okay? So you see these areas of ischemia on the CT scan. They're classic findings on MRI or CT of ischemia that happens from hypertension that was corrected way too quickly, or in like hypertensive bleeds as well, right? So this is why we have permissive hypertension for ischemic strokes, right? We want it to get the perfusion it needs in the meantime. All right, these kind of strokes are called watershed infarcts, right? If you correct the BP too fast, you have these watershed infarcts. All right, your hypertensive patients are used to a high blood pressure, right? When they have all this high blood pressure, they're going to start scarring off and hypertrophying their blood vessels, and they're going to have vessels that are much, much thinner in diameter. And we know that can lead to lacunar strokes, but also, brain wide, they're used to a high blood pressure, right? So these guys should expect a little higher blood pressure when they have chronic hypertension compared to someone who doesn't, right? So that's the idea behind bringing the blood pressure down too quickly. But in other words, if it's more than 180 or 120, that's technically a hypertensive emergency. And we have end organ damage. And what's end organ damage? When I have a bleed in my brain, that's end organ damage. When I have a troponin elevation, that's end organ damage. When I start having kidney failure with creatinine elevation, that's end organ damage, right? When I start having a pulmonary edema because it's busting through the vessels, that's also considered end organ damage. So there's all these symptoms of end organ damage. Same thing with an aortic dissection. That's also a symptom of end organ damage from hypertension, right? So, intracerebral hemorrhage, aortic dissection. You can have hemorrhage. Then we talk about just different blood pressure targets. It makes sense to talk about it here as well. But what we say that the goal BP is for hemorrhagic strokes, be about 140 to 160, right? That is our goal, right? 140 to 160 is where you want to bring your blood pressure down. You want to bring it down within hours, right? So within 4 hours at least, right? So less than 4 hours is ideally where you want to get your hemorrhagic strokes under control, right? So you come in a blood pressure 190 and you did a CT scan, so I got a headache, right? And they say I can't move my right arm, and you go to CT scan, you realize they have a hemorrhagic stroke. So now you have to, the blood pressure was 190 before, now we have to get their blood pressure down to what? 140, 160. Why not 180 or 110 or 185 or 110? That was all ischemic stroke talk, right? Ischemic strokes was where you were doing, TPA or not TPA, permissive hypertension or not permissive hypertension. We talked about all that stuff with ischemic strokes, right? And those ones, you get the blood pressure down, and if you can, and they meet criteria, you can give TPA or TNK, right? Thrombolytics, right? So TPA or TNK, right? And then otherwise, if we have a hemorrhagic stroke, 140 to 160 is where we want our blood pressure. All right, so just talk about hypertension in general. If you have really, really high blood pressure, we obviously want to bring it down too slowly. Otherwise, we'll get this watershed infarct because of because the brain is used to a higher flow, right? But also, if they have a high blood pressure and they don't have an ischemic stroke, they don't have a hemorrhagic stroke, they don't have aortic dissection, so they checked all those boxes. And then what's next? So what's next is just 25% reduction over 24 hours, right? So we tried the math on Monday, we failed. So let's say the blood pressure is 200, right? So we want to get a 25% reduction. What is that? Good, 50 points. Sorry, I got worried for a second. All right, so 50-point reduction is all you want over the next 24 hours, right? So nothing less than 50 points. So nothing less than 150, right? Would be where you would be. That would be your target. Yes?
Should we be pushing for like MAP parameters instead of?
So all the studies were done, or do we choose MAP or systolic blood pressure? All the studies were done on systolic blood pressure, unfortunately. And we know MAP is a better target, especially for shock states. And all the studies on shock were done on MAP. So and all the studies on hemodynamics were done with MAP as well. So we got to kind of meet somewhere in the middle, right? We definitely know we don't want a high CPP, right? Too high of a cerebral perfusion pressure can just be as bad as too high of a systolic, right? Yeah. So usually 70 to 100 is usually where we want MAPs to be or CPPs to be, right? So you have to consider if you do have an ICP drain, great, you can get an accurate CPP. But if they have this huge bleed in the brain, then we don't, is it 5 points of ICP, 10 points of ICP? You'd say 10, but if the patient's like intubated and unresponsive, let's say 20, right? And they should have an ICP in the first place. But you could kind of guesstimate it. So if your MAP is like hovering around 70, that's not going to cut it. We probably want a MAP about 80, right? And if you just know from practice, like a MAP of 100 is probably about 160 systolic anyways, 170 even. So yeah, you can ballpark it. So that's the best we can do to kind of estimate where we should get it. But you don't want two targets. You don't want to say to get it from MAP of 100 and systolic at 150. You're going to go crazy. You're not going to be able to hit those two parameters. It's like lottery, right? Your odds are going to go very, very dramatically down. We need to have one specific target for any titratable drip, right? And what's the drip of choice here? For high blood pressures. Nicardipine is our blood pressure drip of choice, right? Nitroprusside has all kinds of bad side effects, and it's extremely rapid, and it can cause, cyanide toxicity if they have renal failure. And of course, we could use esmolol, and esmolol is actually preferred with AAAs, right? Or up here with AAAs within minutes. You want to get the blood pressure down immediately to 100 to 120. But yeah, so those are our ideal drips, and we talked about those with our antihypertensives back in IV titrations, right? So those were all a hypertensive emergency, right? So we had an emergency situation. How do you know it's an emergency? Because there is end organ damage, right? Hypertensive emergency is a high blood pressure with end organ damage. That's the definition of it. And then of course we have, what if they're not end organ damage? What if it's just they have a high blood pressure, right? And there isn't symptoms yet. So that's called a hypertensive urgency. But again, I said this before, they said that was too confusing, right? Emergency, urgency, crisis, which one's which? So they say, hold my beer. I'll let you know what it is, right? We're gonna make it super clear. We're gonna call it asymptomatic markedly elevated blood pressure, right? So that's gonna be perfect, right? Everybody's gonna love me right now. And the guy's like, anyways, he was fired. So yeah, they have that is an asymptomatic markedly elevated blood pressure. We have a blood pressure that's elevated, but there's no symptoms of end organ damage, right? Or you can just say urgency, right? Anybody that's gone to school in the last 20 years, they know that that's what that is. Okay, and then of course you might not see anything, but then they might be altered, right? There's no CT scans of hemorrhage, there's no damage on MRI, but they have this negative CT MRI and a high blood pressure. Sorry, they got a high blood pressure, no end organ damage, labs are clean, no creatinine, troponin, everything's great, but they are just super confused, right? That's called a posterior reversible encephalopathy syndrome, or PRES. Right, so PRES is where they have this, encephalopathy. We can't explain it. It's just, but everything else is great. Ammonia's perfect. BUN's perfect. They weren't hypoxic. They're not hypercapnic. pH is corrected. They're O2 stats are good. What's going on? Why are they like this? Right? There's no mechanism of injury. They're not a trauma. So then you just kind of say, oh, I guess it's just but they did have a high blood pressure when they arrived. Our blood pressure was like 240 when they came in, right? So that's what PRES syndrome is. Okay, and then again, hypertension is a compensatory mechanism. It's compensation for lack of flow to the brain. Your brain is auto-regulating to get flow to itself, right? It's vasodilating and allowing more blood pressure to get through so that you can get around the hemorrhagic stroke or get around the ischemic stroke, right? And just so you know, as we mentioned, hypertension does cause both strokes, right? And it's by different mechanisms, but it does cause both, and it's something that needs to be managed, either on the outpatient side, once you get discharged, or on the inpatient side, we gotta get the blood pressure under different targets right here. It's just all kinds of different targets from different organizations, the European Society, for the American Neuro Association. There's all kinds of different targets, but again, 140 to 160 is gonna do you good. 180, I probably would not like that. I want 140 to 160 is ideal. And ischemic strokes have a different ball game, right? They're all about, whether it's, thrombolytics or not thrombolytics, right? If it is thrombolytics, what do I do? Blood pressure needs to be thrombolytic candidate, 185, 110, right? If they're not a thrombolytic candidate and they are an ischemic stroke because their CT scan was negative, then I know that I can give, or it showed areas of ischemia, then I could give I allow the blood pressure to be high. I allow it to be as high as what? I permit it to be as high as 220 over 120, all right? So get it all the way up there. It's cool. That's perfectly fine. Once it's over 220 systolic, that's when I'm going to pull out my IV push of labetalol, my IV push of hydralazine, okay? And if it sustains high, then that's why I pull out my nicardipine drip infusion, okay? So that's the idea. All right, so the bleeds, the hypertensive bleeds themselves. So we talked about how to fix it with blood pressure medications, but how do we, where does it happen? All right, so about 60% of the time, like more than a coin flip, you're going to see it in the basal ganglia region. So where the heck's the basal ganglia? It's like, I got you. It's lateral. It's lateral to the thalamus. It's like, okay, well, where's the thalamus at? Well, it's lateral to the third ventricle. All right, so here's my third ventricle right there in the middle, right? So third ventricles, lateral ventricles are kind of the butterflies there. If you go down one level, the thalamus is right next to it, right? So this is a left thalamic bleed. There's a right thalamic bleed. We have the thalamic bleeds, right? And thalamic bleeds are on the list too. 1 in 5 patients, 20%, develop a thalamic bleed. And then if we go just lateral to that, right? So there's our thalamic bleed. So this is where a thalamic bleed would be right there, right? But we just go lateral to it. We have, which is white on CT, right? We'll have a basal ganglial bleeds, right? So basal ganglial bleeds are above by the thalamus. Okay. Okay. So basal ganglial bleeds and thalamic bleeds, and then we have other more worrisome bleeds. Luckily, they are it's 1 in 10 patients that get a hypertensive bleed. They'll get a bleed that's on their cerebellum. Is that okay? No, it's a box within a box, right? It's very, very easy for that to expand, and then there's nowhere for it to go. The only way to go is down through the brainstem, right, through the foramen magnum that's there, right, or upwards and start compressing the brain upwards. And then there's no room up top because there's a nice big hard skull up top, and now it's going to go back down the way it came, right, the way it was going first. So cerebellar bleeds are very, very ominous signs, right? Sometimes you'll get a patient from the ER and they'll say, I want Q1 hour neurochecks. Patient looks absolutely fine. Why is this patient even in ICU? What the heck's going on? They're on their phone, they're texting all the time, they're looking fine, they're watching TV. There's no reason for this patient to be here, right? And then you go in the next hour and they are not responsive at all, right? And now you're intubating them because their cerebellar bleed grew, right? And again, it's our job to figure out maybe what's the underlying cause. You can ask them while they're awake, do you take anticoagulants, right? Do you take a 10A inhibitor? And you can see on the monitor, maybe they have AFib, right? It's like, well, you take anything for that AFib, right? So these are high-risk patients, okay? Obviously, the deeper you get with pontine bleeds, you definitely get respiratory symptoms. You can get the brainstem being infarcted, so there's our pons being infected as it goes down.
I'm sorry, Aaron.
All right, so so those are our different types of bleeds. The last type of bleed is lobar bleed, where it just bleeds into one of the lobes. It's not as common as a bleed into the cerebellum or the pons, right? Or even down, even further. Okay, just so you remember what basal ganglia does in the meantime. Remember Parkinson's disease, right? Basal ganglia is all about movement and smooth movement, right? With the substantia nigra, all these fun different nuclei that are involved in smooth movement of motor systems, right? So coordinated movement and smooth movement. And then our limbic system is just right nearby and it gets affected as well, right? It's the 5 Fs, right? What are the 5 Fs? We talk about gallbladders, a different 5 Fs. But for this one is food, right? Flight, fight, furnace, and fornication, right? So those are our 5 Fs for the limbic system. All right, so all these are symptoms or are locations for a hypertensive bleed. And you can see these different bleeds on the CT scan. The thalamus right out of the third ventricle. We have the pons right there as we go down through the foramen magnum, right? Cerebellar bleed. We got a temporal lobe bleed over there. I guess putamen is another word in close. It's nearby with the basal ganglia, right? So we have this huge bleed right here. That patient did not make it. All right, so symptoms of intracerebral hemorrhage. These should look familiar, the same things we do for ICP, all right? There's very few differences, right? So our symptoms are just a stroke-like symptom because we're interrupting blood supply to an area of the brain, right? Whether it be an aneurysm or a lobar bleed or whatever it may be, it's going to cause a localized symptom. And it's a lot more rapid in development than compared to like an ischemic stroke, right? An ischemic stroke doesn't, yes, you get cerebral edema there, but it's not going to be very, very fast, right? Compared to a bleed that can bleed and bleed and bleed, right? This is why you don't want those patients to be like sitting in the corner somewhere waiting for their CT scan, right? They should get their CT scan right away and they should be assessed frequently, right? So ICP goes up. We got our ICP symptoms we talked about before. They got that headache, intractable nausea, vomiting, a drop in their LOC, and as it starts herniating and herniating and herniating, we start getting Cushing's triad and our different herniation syndromes where you can like compress the cranial artery 3, the tentorial herniations, all those structures start getting involved. Our CT scan, as we know, has white blood on it, right? And then how do you fix it? It's the big 6 to fix is kind of the mnemonic, right? Blood pressure needs to be good. What's the blood pressure for intracerebral hemorrhages? 140, 160, right? That's our goal. And again, here's just reference to different organizations that say, if you have a spontaneous, let's do 140 to 180. If you have a subrectal hemorrhage, 140 to 160. If you have a, hemorrhagic, it goes all the way down, right? There's all kinds of different ballparks, but 140 to 160 is usually going to get you by. Okay, so 140 to 160 within 2 to 4 hours, right? Ideally within hours, you're getting that blood pressure immediately down to where you need to be. Aortic dissections, those are within minutes. Like you have little minutes to get the blood pressure under control. The blood pressure is like 170, right? These ones you have a little bit of time, but you still want to get something started. Okay, you want to avoid vasodilation, as we know. What could vasodilate someone? So like, oh, I got a headache, I got nausea, vomiting, and I'm going to give you some morphine to control your headache, right? So the morphine can then cause them to get decreased respirations, and then now you have hypercapnia to develop, and now CO2 is going up, and that's vasodilating in the brain. So that's not great. Okay, make sure everything's normal. Make sure that our glucose is good, right? That's a quick, easy fix. Because if glucose starts getting low, that could cause cerebral edema. We know glucose can mimic strokes. Does it mimic hemorrhagic strokes? Technically, right? But yeah, so glucose is a big deal with ischemic strokes, and here you want to avoid it. You want the glucose normal because you want to avoid secondary injury from low sugars, low O2, high temperatures, right? Seizure activity can develop as well. So usually we're giving some seizure prophylaxis, especially if it's in the cortical areas, out in the cortices. We're definitely get some seizure prophylaxis. And then what else? Reversals for anticoagulants, as we mentioned, right? So we're avoiding, if they get a history of anticoagulants, then we should probably ask for a reversal agent. And you could get reversal agent for warfarin, which is what? You want to say vitamin K, but that's going to work tomorrow, right? Vitamin K is going to get processed and it's taking half hour to hour to get absorbed, and it's going to tell your liver to start reusing the coag factors that it was not reusing before because they had warfarin, and now you're going to now tomorrow you're going to start recycling, right? Just like the dishes in the sink, right? Tomorrow, right? So that's going to be a quicker fix for that. So FFP will fix it in 4 hours, right? It'll provide the coag factors, and they'll get thawed at 400 degrees for 4 hours, right? And then what's next? What's the better option? That's PCC, right? So PCC, or prothrombin complex concentrate. That's the one we want to give if someone has an intracerebral hemorrhage due to anticoagulants. You don't give it if someone just has intracerebral hemorrhage, like an aneurysm that ruptured, right? It's more for someone that specifically is on anticoagulants, right? PCC, yes, it's expensive, but it is a reversal agent for every anticoagulant. It's always the right answer, right? If you have an extra $40K to spend, you can spend $40,000 more than $8,000 of PCC, right? And what can you give? And Dexanet, which is the reversal agent specifically for our 10A inhibitors, like rivaroxaban and apixaban. Okay, as we mentioned, if you have an aneurysm from intracerebral hemorrhage, that's where you're going to get interventional neurology involved. And what can they do? They can intervene neurologically, such as what doing what? They can do coiling, right? Can they do a clipping? No, you need a neurosurgeon for that. Neurosurgeon, you have to flip back the skull, you got to pull the skull back, and this is actually a hematoma they're taking back. But if you look at the actual videos, they're pulling a whole brain forward and getting there to clip as best they can. Okay, and of course, our goal is to avoid any kind of secondary injury. ICP will very likely be indicated, especially if our GCS starts going down, and especially if we start getting extension of our hemorrhage into the ventricular system. You need a external ventricular device or an EVD no matter what, right? So you get the BP under control, you're preventing any kind of, if you are intubating them, we know that can be stressful, so sometimes they even recommend like lidocaine as an option, but we're getting coagulopathies fixed, right? Get everything normal, glucose temperature, and ICP and seizures need to be fixed, right? So it's the big 6 to fix. So here's our coiling right there by IR, right? And the clipping is by cranium. They've pulled back the brain and they have clipped the little area of the circle Willis that has ballooned out. Okay, that makes sense. That's how we fix intracerebral hemorrhages.